So I want to first start by thanking the organizers for inviting me and for this wonderful theme of the meeting about the older generation, however you define old, and for all the gracious and warm hospitality of my friends out here in the audience. I love Israel and I love Israelis. You are a great country and a very diligent and important people, and your contributions to medicine are many. So Yossi Klauser and others know the answer is always yes when I have an opportunity to come here to visit. So you've heard many talks during the last 2 days about the elderly population. I thought as I listened to that, I changed my talk a little bit to talk about the errors of omission in the elderly, because you've heard a lot about the errors of commission. And if this works, I think one of the things we have to think about as we talk about so-called elderly population is this is a very dynamic and changing population of individuals, and it's a very heterogeneous group of individuals. First, life expectancy has increased substantially, as has the fitness of the elderly. So in the past, when I was in practice 20 years ago, the elderly population was defined as those over 65, maybe 70. Now, very clearly, and even that's an artificial boundary, those at 80 or more, I think, would be fairly defined as elderly. And what's interesting now is 1 in 3 babies born today, at least in the United States, are expected to live to 100 or more. And actually, I took a photo of the front page of Time magazine just a few months ago, which said this baby could live to be 142 years of age. So part of my message is we cannot and should not define elderly by our chronological age, but really the physiological age. Just to be personal, I'm 73, I'm in excellent health. My brother, who's 10 years younger than me, has already died of heart disease. Just to show you by example that you can't go by someone's age and predict from that their risk for surgery, especially if the decision is to not proceed with surgery. So my message throughout this is to treat our patients based upon physiological age, not chronological age. Understand that the natural history of many different cancers varies. For example, in melanoma, in older patients is actually more aggressive than in younger patients, but conversely, breast cancer in older patients, even large tumors, are generally more indolent and more hormone sensitive and therefore more treatable than those in middle-aged individuals. As you've heard today, that geriatrics is a bona fide specialty, and as we have patients that we define as having comorbidities, especially multiple comorbidities or frail, that a preoperative evaluation and helping patients maximize their reserves before an operation instead of reacting to their situation afterwards can get many patients safely through an operation. I think we have to remember, too, that anesthesia is much safer in the past. I've been doing breast cancer for 40 years. Most of the patients that I operate on today have sedation anesthesia and go home that night or the next morning. They don't even need intubation. There are now, as you've heard, many predictive tools on surgical mortality and morbidity that are available. And most of the older literature on surgical risk that we use today is no longer relevant because of these changes that I've told you up above. In preparation for this, I did a lot of reading about geriatrics oncology. This has not been an area of focus for me, although, like all of you, I take care of older cancer patients and have regularly. But I wanted to commend to you these 2 very nice reviews by my friend who is a world expert, Riccardo Adisio at Liverpool, who is also the editor of the European Journal of Surgical Research and is currently president of both the British and European Society of Surgical Oncology. These are two excellent articles, one published recently in August last year, and the other, which is also still very contemporary, in 2007. So Ricardo actually shared some of his slides. So if you see deep blue slides, they're mine. If you see the light blue slides, these are Ricardo's. So I want to be sure to give him credit. But I selected a few that I thought were also very good teaching slides that hopefully will complement some of the information that you've gained earlier in this meeting. And I think part of this is thinking strategically about patients and how to take the heterogeneity or diversity we know is among the older population and to try to categorize them into different risks. Because in the end, the recommendation we make to an individual patient is, for a given operation in an individual patient, does the benefit of the procedure outweigh the risk? And sometimes we have to say, does the benefit of not operating outweigh the risk of not operating? And sometimes that's a more difficult decision making. But I thought this was very insightful of showing that virtually everybody in this room is in a state of deterioration if you're older than age 30. And as you can see, part of that, as we get older, is our functional reserves decline, some more than others. So I show it here at 70 years of age. There's a mixture of patients who have less reserves that we call upon during anesthesia and an operation or the complications such as infection. But there are also many patients that may be still physiologically young and have maintained the reserves because over the years they've practiced good health in their eating and their exercise, and they may have inherited good genes as well. I thought this was also a very insightful slide that Ricardo had shared with me. If you take age 80 as a threshold and look at the percentage of patients that may have moderate to severe comorbidity, that's about 40% of patients. That means 60% of patients at that age have no or mild comorbidity, and at least in breast cancer and many other operations should be able to safely get through an operation. And yet, as I'll show you, the literature is replete with information that patients at this age are denied an operation by the surgical community because they're too old. So I would maintain that in this group there is no reason to undertreat. And in fact, this slide I think shows that the errors of omission in our surgical decision making may be even greater than our errors of commission by operating on patients who may have risk or haven't been fully prepared in their nutritional status or pulmonary or cardiac status prior to an operation. So I'll just go through a few slides very quickly because the evidence is pretty overwhelming that despite the fact that intuitively we say, yes, we're going to operate on all patients, if one looks at data at national levels, the evidence is not very good that we actually give older patients a chance to get through an operation such as breast cancer, which, as I say, should be day surgery or overnight surgery. This is not like a pancreatectomy. But as shown in this slide from Ricardo, if one looks at patients whose breast cancer or colon cancer was confirmed by histology, you can see in the older population that a quarter to a third never had confirmation of their histology. This is a study in Great Britain that 11% of breast cancer and 31% of colon cancer patients had no definitive treatment at age 75 or greater, and either because of the biology of their disease or their undertreatment, their survival rate at 5 years, this is disease-specific survival rate, is less than in the younger population. So in this in this publication, breast cancer women 75 years or greater are less likely to receive all of the usual standard treatment that we would recommend to those patients, even though, as I showed you earlier, at least half of those patients have little or no comorbidity that should have precluded an operation. And if one looks at their guideline therapy, and I'll show you this on the next slide, I think, these are patients under age 75, 1 and 2, who received therapy according to standard guidelines. Number 3 are those who are 75 years of age who received guideline therapy. They did the same as the younger patients if they got the appropriate therapy. But those who did not receive the guideline therapy, you could see, had a significant decline in their disease-specific mortality after that. So remember, if you're seeing a patient who's 75 or 80, many of those patients may have a life expectancy of 5 years, 10 years, 15 years or more, and they should not be denied that based upon their chronological age. So these are just some examples. Here's another one that I selected from more recently. Elderly patients with breast cancer, again, this is from the United States, had less axillary sample, fewer mastectomies, less radiation therapy and hormone therapy, and in fact, 51% of the elderly patients in this series were undertreated by conventional criteria. Here's yet another one. Again, this is from Great Britain. From age 70, there is an increasing failure to operate for breast cancer. Older women with larger tumors, which were otherwise good prognosis, hormone responsive, this would not account for the failure to operate, which may in part be related to comorbidity in this group. Yet another study, this one from Switzerland, showed that an increase in incomplete diagnostic assessment and substantial underuse of breast conservation surgery, post-breast conservation surgery radiation, sentinel node dissection, adjuvant, endocrine therapy in elderly breast cancer. And this prospective Swiss study concluded that there is a need for improved management of early breast cancer in the elderly, even in a system such as Switzerland or in Israel, where there's universal access to healthcare services. And finally, this is a study in the European Journal of Cancer. This is very recent. Variations in compliance according to quality indicators in 42,000 breast cancer patients across Europe. And what they found was compliance to the quality indicators for patients aged 75 or greater was significantly lower compared to those in the next cohort of age groups for the 10 quality indicators. While in patients for the youngest group, this was in the true even for 7 quality indicators. By young, this is 35 or under. And in conclusion, they found among the 27 breast units across Europe, compliance to quality indicators for breast cancer treatments is often lower in the youngest, under 35 years of age, and oldest, greater than 75, with a tendency to overtreatment in the youngest patients, that's another issue, and to undertreatment in the elderly. And then finally, this from a European article that I picked up of ending age bias in breast cancer treatment. And what they said, despite age discrimination in healthcare being against the law, many older people may not be receiving the level and type of support and treatment and information that they need. Here are 2 examples from my own personal series. I'm well known in melanoma, but half of my practice for 35 years was in breast cancer. And in my practice at Johns Hopkins, I selected these 2 patients because it was actually somewhat controversial among my peers that I was doing this operation in these elderly patients. The first is a patient who had a large, probably about a 8-centimeter recurrent mass at level 2 and 3, who'd had a partial axillary dissection for a breast cancer. This was impinging on the brachial plexus, and she was even beginning to get brachial plexopathy and the axillary vein. She had been turned down by 2 surgeons as inoperable. But in fact, those surgeons never trained on a Halsted radical mastectomy and didn't know how to approach the level 2 and 3 in a subclavicular incision. I did in this healthy 75-year-old lady, I took this out as outpatient surgery. She went home that night after the neurosurgeon and I chiseled this off the brachial plexus. That was 6 years ago, and she's been disease-free since, in a patient who had been declared inoperable by 2 other surgeons. Here's another example of a 74-year-old lady who came to me with lobular carcinoma and LCIS in her breast and a very abnormal mammogram on the opposite side. This informed lady came me with the treatment she wanted, which she declared within 2 minutes of the outset. I want bilateral mastectomy and tram flap autologous reconstruction. And I said, whoa, that's a big order for your age. But this is a lady who plays golf several times a week. She's physically fit. She goes to the gym. We carefully evaluated her, and we actually did that operation. And the reconstructive surgeon commented that the elasticity and softness of her vessels when he plugged them in were equal to a patient he'd operated on who were 20 years younger. So again, my point is these patients did well. They both had quality and quantity of life that they might not otherwise had based upon an age bias. So we as surgeons are at risk for undertreating older cancer patients when overly concerned about comorbidities and not working with these patients to maximize their physiological status to do an operation, and of overtreating older cancer patients when frailty is not taken into account. And of course, the definition of frailty or sarcopenia, which you've heard about throughout this meeting, is very important in a variety of ways, most importantly to get a patient through safely through an operation. And of course, as you've heard, more information about this is needed. I'm not going to go through all of the different predictors of mortality and morbidity, as you've heard here. Just a couple examples. And again, this was, I think, published just a month ago in the European Journal of Surgical Oncology, again by my friend Ricardo Adisio. And what he found in predictors of adverse outcome in oncogeriatric patients, those over 80, is while a substantial number of patients experience major postoperative complications, actually 16.8% to me in this group of patients is not a big number. And the get up and go, the ASA, the anesthesia assessment, and the nutritional risk score, together were screening tools predictive of the occurrence of a major postoperative complication, and together with gender and type of surgery, comprise a good scoring system. So I would commend this paper to you that was just published. They also have talked about the PACE assessment, which has been published again in this journal as a predictor of complications in surgical patients. And one you probably haven't heard about, which I would also commend to you, is an online predictive tool from the American College of Surgeons using this very large database from the National Surgical Quality Improvement Program. And this online calculator predicts risk of surgical complications. And I'll just walk you through just one example that I put in as an elderly patient, 75 to 84 years of age, had oral diabetes, partially dependent, had severe systemic disease in the ASA class, moderate dyspnea. Weight is shown here. So you can put on all of these parameters and then download this and go over it with the patient and their family. The predictive risk of death in this patient for a colectomy with anastomosis was 7%. That's above average. 45% risk of complication. But you could also see those complications that have a higher risk than others to be proactive about and hopefully mitigate or prevent. So this is, I think, just another tool, an online tool that is based upon a lot of data. In the interest of time, I'm going to go over this very quickly, but I just wanted to point out that generally there's no difference in patient-driven mastectomy, partial or total, in the elderly versus younger patients when they are medically fit. And there's an increasing trend towards neoadjuvant therapy, either endocrine or chemotherapy, which I think should not be denied patients in the elderly population, again, if they are medically fit. There's a trend towards more conservative treatment in elderly frail patients, the majority of whom have hormone-responsive tumors that can get a good response with hormone therapy, with or without radiation. And here's what I think is also important. We tend to dismiss reconstructive surgery in the elderly because they're too old. And yet, if you ask these patients, they're not interested in being in a bathing suit or a strapless evening gown. They want enough symmetry they can get in their bra so they don't feel like they're disfigured or uneven. And we should give them at least that so that they, at the end of the operation, however you do it, have a symmetry of their breasts that they can wear their clothes. So even in the elderly, it's very important, I think, to allow patients to maintain the same style of clothing and dress as before the diagnosis of breast cancer. And that means we as surgeons, either by our own training and experience or with plastic surgeons, need to achieve symmetry with what's now called popularly oncoplastic surgery, or if necessary, these next two slides are older patients who have had skin-sparing mastectomy with immediate tissue flap reconstruction, shown here, in order to achieve symmetry. Principles of hormone therapy among these patients is important. Now, one of the other issues among the elderly, and I'll show this to you in the next slide, is compliance. Some of my patients take 5 to 8 different medicines, and we're asking them to take yet another drug for 5 to 10 years. And we may consider for these larger tumors reduction in their tumor with preoperative endocrine therapy in order to give the patient the most option and to understand how responsive their tumor is to endocrine therapy at the beginning. And where it's available, I think it's pretty clear that the aromatase inhibitors, while they're more expensive, are superior to tamoxifen. And I picked this, I guess it may be later on, that the compliance rate for tamoxifen at 5 years, only 50% completed 5 years of therapy with tamoxifen. So one of the issues we really have to work on in the elderly population is compliance. Now, several people have talked about it. I wanted to also add that elderly patients are excluded from clinical trials. So the results that we apply by extrapolation to the older patient population was derived from a younger population, which may or may not be appropriate in the older population with more comorbidities and taking more drugs with drug-drug interactions that we don't always know about. But in this paper from the Journal of Clinical Oncology, in a multivariate analysis of comorbid conditions, age and stage were the only predictors of whether a patient was offered a clinical trial. And the greatest impediment to enrolling older patients in the trial was the physician's perception about age and tolerance of toxicity, or the trial itself excluded patients over the age of 60 or 65. So, as Dr. Adisio had shown, I think this is a very nice contrast. We're studying patients who are under age 65, which is actually the minority of breast cancer patients, and we're not studying the older patients, which is the majority of patients with breast cancer. It's paradoxical. So this was the one that I was showing about tamoxifen being a well-tolerated drug, and yet patients, there was variation in age of patients not undergoing surgical treatment. You can see it goes way up over age 70 and especially age 80. And interestingly, patients may, at an older age, may get more hormone therapy, but less radiation therapy and chemotherapy especially, even though they might be medically fit and able to tolerate it. And remember, the older population is getting older but is more fit, and therefore we shouldn't use chronological age. This is just another example. This article about the adjuvant online is not predictive in the older population because they weren't studied in the original studies, and now we found that it is not as predictive of survival rates as in younger population. This was the study, I guess I put it in the wrong place, a very nice study showing overall adherence was 50% by year 4 of therapy in the older population, again emphasizing the importance of compliance. And I did want to show you one good result from a clinical trial in the elderly population, and this from the American College of Surgeons before it got folded into the Alliance Group. This was a study by surgeons using neoadjuvant aromatase inhibitors, where patients were randomized to one of these three. To get into this, they had to be postmenopausal, ER positive, and they had to be candidates only for mastectomies. Because of the size of their tumors, they were not candidates for breast conservation surgery. So they were all stage 2 and 3. I had, just as an example, one of the patients I put into this was an 82-year-old patient with bilateral stage 3 breast cancer. She went on to letrozole, and by the time she completed her preoperative assessment 60 days later, she had no palpable disease left behind. Now, we did do, according to the protocol in standard therapy, bilateral mastectomies, and she stayed for 2 days. She didn't turn a hair, and she did just fine. But what I wanted to show you on these patients, all of whom required mastectomy or were inoperable prior to getting their neoadjuvant therapy, that 56% of them had a downstaging with just an oral therapy that allowed them to either have breast conservation surgery and radiation or a mastectomy. So this trial showed a conversion from mastectomy to breast conservation in 51% of patients. This is an older population and shows the value of it. So in summary, older breast cancer patients tend to be understaged and undertreated compared to younger patients just based upon their chronological age. We should treat patients based upon their physiological age, their comorbidity, and their estimated reserves in these predictive tools, not on their chronological age. Remember, babies born today, those of you in the younger generation here, will have an average life expectancy of 90 to 100 years of age. So you can't use the old literature with these artificial boundaries we've created of age cutoffs. We need to co-manage the non-cancer diseases as appropriate and estimate which is the most life-limiting, engage geriatrics and rehabilitation specialties as appropriate, engage the patient as a student in their disease with an emphasis on the importance and value of complying with their therapy, especially their long-term therapy. And as in other cancers, a multidisciplinary care, combining surgery, systemic therapy, depending upon their biomarkers, and radiation therapy, if appropriate, gives the best results, even in the older patients. So I think this is my final slide. Knowing the natural history of the disease, accounting for comorbidity, and using these predictive tools which are available, maximizing the surgical outcomes of the elderly, even those with comorbidity, and the age bias in the literature, I think, is something that is becoming less and less relevant, and it is also more and more important to do those studies in those patients who are elderly so that we can use evidence-based medicine in the elderly and not extrapolate our data from those who are of a younger age. Thank you very much for the opportunity to be here.